Good morning, everyone. We are just on time. Hopefully, I will be able to deliver my message also in 30 minutes as scheduled. So I will be talking about hepatitis C virus infection in developing countries. Although the topic is about developing countries, speaking just about the developing hepatitis C in developing countries is very difficult because people migrate, people move around. So we have to discuss hepatitis E in the context of its global distribution. So hepatitis E is a liver disease which is caused by hepatitis E virus, and hepatitis E virus infection usually result in a self-limited acute illness. The disease is widespread in the developing world, and in developed countries, locally acquired hepatitis E virus infection is less common. It can result in acute hepatitis with tendency to progress to chronic hepatitis, mainly among people who received solid organ transplantation. Here you can see the electron microscopy picture of hepatitis E virus, which was done in Dr. Balayan's laboratory in 1980s, and above it is a rendering of the viral particle. The taxonomy and molecular virology of the virus. Hepatitis E virus belongs to Hep E virida family. The genome is a single-stranded linear RNA, about 7.2 kilobase. It has 5 genotypes that affect human. There are more genotypes, but 5 of them affect human. There is only one single serotype, and the viral genome has 3 operating frames. Operating frame 2 is responsible for the envelope of the virus. This is the proposed classification of the family Hep E virida, and you can see in this table how many different genotypes of the virus of hepatitis E virus exist, and which one affect human and as well as animals. This is important to understand because this will will have an effect in the future slides. Hepatitis E is most common in developing countries with inadequate water supply and environmental sanitation. Large hepatitis E epidemics have been reported in Asia, the Middle East, Africa, and Central America. People who live in refugee camps or overcrowded temporary housing after natural disasters and wars can be at the high risk of infection with hepatitis E virus due to very close transmission in such settings. There are 2 distinct hepatitis E virus infections. First is the infection that occurs in non-hyperendemic countries or so-called developed countries, and this infection is associated mostly with hepatitis E virus genotype 3. Attack rate in this of this infection is highest among people who are older than 50, and chronic infection was documented in immunocompromised individuals. There is no data on susceptibility of pregnant women to the infection and fulminant hepatitis failure. Most likely the disease is transmitted, is a foodborne zoonotic disease because there were reports of genotype 3 caused and genotype 4 and genotype 7 caused infection after consumption of undercooked boar and deer liver in Japan, liver sausages in south of France, and camelids, meat and milk in an individual from Singapore who lived in Middle East and extensively consumed these products. Another hepatitis E virus infection occurs in hyperendemic areas or in so-called developing countries. This infection causes massive outbreaks associated with genotype 1, and smaller outbreaks were described that were caused by genotype 2 and genotype 4. The attack rate is highest among young adults. There is no evidence of chronicity. Morbidity and mortality is highest in pregnant women. About 10 to 35% of pregnant women might die if they get infected with hepatitis E. And the disease is predominantly waterborne and human-to-human transmission transmitted. Symptomatic hepatitis E is often the result of the travel to a country where hepatitis E is hyperendemic. However, sporadic hepatitis E is not, which is not associated with travel, is more and more commonly described recently, and this slide actually shows some data from Italy where approximately 81% of the cases of hepatitis E were travel associated and travel associated to hyperendemic areas, and only about 16.4% were related to were autochthonous cases. In other countries, this proportion could be different. For example, in the United States, the proportion is approximately 60 locally acquired hepatitis E, and approximately 40% is imported. It really depends how often people travel in those countries and what are their destination. Hepatitis E is believed to be not so common, as I just showed you, in the developed countries. However, a high prevalence of antibodies to hepatitis E with the north to the south gradient was detected in general population and blood donors in Europe. For example, the lowest prevalence that was detected in donors was in Scotland, which was 4.6%, and the highest was in southwest France. A gradual increase of IgG seroprevalence with age suggests also that it's a cumulative effect to the exposure to hepatitis E virus. As you can see on this second part of the slide, that shows data from Germany from a nationally representative sample which was conducted in 2010. What about a trend in hepatitis E virus infection prevalence? Is there a trend or not? It's very important to know whether the infection is, the prevalence is increasing or is decreasing in order to know how much people are susceptible in the country. So in the United States, for example, between 1988 and 2010, anti-HIV IgG prevalence declined from 10% to 6%. The study was conducted on a very large number of samples, more than 10,000, and showed a statistically significant decline. Are there any conditions for hepatitis E virus introduction related to the migrant crisis in Europe? I think this is a very good question at these days, because a large number of people migrated to Europe from regions that are hyperendemic for hepatitis E virus infection. Data are not available for this particular situation. However, I brought in this slide a few data from previous experience and a few data that are available in populations to speculate a little bit what could happen. Anti-HIV prevalence in Europe is predominantly low, as you saw previously, and this results in a large susceptible population in Europe. Migrants from hyperendemic areas are at highest risk of HIV infection because they are young people. As you know, in hyperendemic areas in developing countries, this is the highest risk population. Sanitary facilities and water quality may become compromised in overcrowded migrant camps. And there were several precedents, but I'm going to bring only two examples. For example, in 2003, there was a very limited number, I think it was 2 or 3 cases of hepatitis E in a camp of migrants that was in Czech Republic, in a family that migrated from India. That was genotype 1 infection. They brought the infection with them as they were traveling to Europe. And that's one example, which did not result in an outbreak. It was a localized situation. And there's another example. It's not from Europe, but the conditions are in a way similar. In 2009, a seroprevalence survey in Uganda showed that the prevalence in the population was very, very low. It was below 10%. And migrants from Sudan who came to Uganda brought hepatitis E virus, and there was an outbreak which resulted in about 10,000 cases in the migrant camp. What about the transmission and the exposure of the virus? So hepatitis E virus is spread usually by fecal oral route. In developed countries, sporadic hepatitis cases are result of HIV genotype 3, 4, and 7, and they have occurred following consumption of undercooked or uncooked pork, including liver sausages, deer meat, and rabbit, and also meat from camelids. Consumption of shellfish as well is a risk factor for developing hepatitis E, as it was demonstrated in an outbreak investigation on a cruise ship in England. HIV genotype 3 and genotype 4 in mussels and oysters were described in Europe, and genotype 4 hepatitis E was associated with foodborne transmission in China, Taiwan, and Japan. So the transmission of hepatitis E through the consumption of meat from animals that are reservoirs in nature have been demonstrated. How about the blood transfusion? Is it safe or not? In Europe, blood donors were found to be surprisingly a high proportion of them was found to be infected with hepatitis E. For example, in Germany, 1 in 1,200 donors had HIV, had viremia. And the highest was detected lowest proportion was detected in Sweden, where 1 in almost 8,000 donors had viremia. Donors who have viremia at the time of donation have no symptoms. The liver function tests are frequently normal, and the anti-HIV IgM may be negative. So it's basically a subclinical infection, and it's very dangerous in this kind of situation. Blood donations are not currently screened for hepatitis E virus, and urgent risk assessments are being conducted at this time to determine whether this is necessary to do or not, to screen blood for hepatitis E virus. What about occupational risk from hepatitis E virus? The direct contact with hepatitis E virus infected animals can lead to HIV transmission. It was shown in seroprevalence studies a significantly higher prevalence of IgG anti-HIV when it was compared to general population. It was in veterinarian, in people in swine handlers, and forestry workers. So there is occupational risk. There was no documented cases, but the prevalence is much higher in people who work with swine. Jaundice is the most common symptom for hepatitis E virus infection. It can occur between 47 and 75% of the patients. Anorexia, lethargy, abdominal pain, vomiting, and weight loss are also symptoms of infection. Myalgia, pruritus, fever, and arthralgia are symptoms of hepatitis E, and in about 5.5 to 10% of cases, neurological symptoms may occur as well. On this slide, you can see the results of observation that we did in the United States among people who had laboratory diagnosed hepatitis E and comparable groups that did not have hepatitis E or had hepatitis E in the past. So the people who had who met case definition of hepatitis E had high ALT levels, which was the median was 7 upper times of the upper limit of normal, and the range was between a few cases where ALT was normal to all the way to 1,000 or even 3,500 units per liter. The ratio of symptomatic to asymptomatic infection ranges between 1 to 2 cases to 1 to 13. In developed countries, sporadic cases due to hepatitis E virus genotype 3 mainly affect older men, 40 or even older than 50 years old. Acute and chronic hepatitis E virus infection occur in solid organ transplant recipients on immunosuppressive therapy. However, in developing countries, symptomatic hepatitis E is common in older adolescents or young adults between 15 to 44 years. Pregnant women are more likely to experience severe illness, including fulminant hepatitis and even death. Incubation period for hepatitis E is between 15 and 60 days, and the infected individuals can be infectious for a period between 1 week and about 30 days after the onset of the jaundice, which was demonstrated by detection of HEV RNA in stool and serum. Chronically infected people shed the virus as long as they are infected until they resolve. And hepatitis E is, as I said before, it's a self-limiting disease. Most people with hepatitis E recover completely. However, hepatitis E could be serious among persons with pre-existing chronic liver disease, and it can result in decompensated liver disease and death. In developed countries, high mortality may affect solid organ transplant recipients that are on immunosuppressive therapy. Can hepatitis E become chronic? Yes. Hepatitis E was demonstrated to become chronic, and it becomes chronic after the observation for at least 6 months. This is the definition of a chronic hepatitis E. ALT is moderately elevated with median 187 and the range between 16 and 3,400 units per liter, but mostly it's just moderately elevated. There is no difference in hepatitis E virus load during the acute and chronic phases of infection in people who chronicize, and there is a decline in clearance in people who are treated and resolve hepatitis E virus infection. Initially, hepatitis E virus, chronic hepatitis E virus infection was described in solid organ transplant recipient with more profound immunosuppression that were on tacrolimus and with low platelet count. In solid organ transplant recipient patients, there is no spontaneous hepatitis E clearance between 3 months and 6 months after infection, which suggests that chronic infection is basically established after 3 months of infection. Chronic hepatitis E was also described in patients who are infected with with HIV, and patients having hematologic disease and receiving chemotherapy, as well as patients who received stem cell transplants. Chronic hepatitis E was associated so far with HIV genotype 3 and one case of genotype 7. There is no chronic cases associated with genotype 1, 2, or 4. Diagnosis can be confirmed only by testing for presence of antibody IgM or IgG and IgG or HIV RNA. In Europe, both serologic and nucleic acid tests are commercially available. In the United States, unfortunately, FDA did not license any commercial tests, but they are available for research use only, and after internal validation can be used. There are increasing numbers of autochthonous hepatitis E, and therefore testing for hepatitis E virus infection should be considered in any person who has symptoms of viral hepatitis, regardless the travel history. Unfortunately, in the past there was a concept that we have to test only people who travel abroad, and therefore a lot of locally acquired hepatitis remained in the shadow. It was not diagnosed. On the left side of the screen, you can see the serological profile of hepatitis E virus infection. There is a triad that I usually use when review laboratory results. Laboratory result review triad, I call it. And this triad includes interpretation of the lab results in a clinical epidemiological context. Don't look at the result just as a laboratory result. You have to know what is going on behind that result. You have to know the clinical and epidemiological context. Comorbidities can cause false positive results. The review of the processed or raw data also helps with determining whether the result is false positive or is true positive. Usually true positive results are likely to have high signal to cutoff ratio or optical densities value. If the results are with low signal to cutoff ratio or optical values, and you are not sure how to make a decision, it's recommended to take a follow-up sample a week later, and you will see the dynamic, because if there is an infection, you will see a dynamic of that infection, either increasing of signal to cutoff ratio or decreasing in a resolving infection. And also you have to consider the test specificity, because poor test performance of some manufacturer can result in false positive results or false negative results. Lab developed and not properly validated tests might be unreliable due to lack of standard quality control and quality assurance procedures. And also it's important that you send the results to you send the sample for testing to a laboratory which is accredited by ISO, by CLSI, College of American Pathologists, or CLIA. How is hepatitis E treated? Hepatitis E usually resolves without treatment. However, and physicians should offer supportive therapy. Hospitalization sometimes is required when the cases are severe. However, in solid transplant, organ transplant recipients, with chronic hepatitis E, decreasing immunosuppressive therapy might be a solution to help resolve the infection. The clearance in such situation occurs in about 1/3 of the patients, and if that doesn't help, then treatment with ribavirin was demonstrated to be quite effective. How we do hepatitis E surveillance? Hepatitis E surveillance is kind of not very easy to do because in many places it's not reportable, and therefore the laboratory-based surveillance is recommended. That's what we do in the United States. Or if, for example, in Germany and other European countries, hepatitis E is reportable, then it's easier to do reportable disease surveillance. Seroprevalence, of course, is determined by conducting populational surveys. Good sanitation, safe eating habits, and clean drinking water are the key for prevention of hepatitis E. Immunoglobulin is not effective in preventing hepatitis E, and there is a vaccine for hepatitis E. However, it is licensed only for use in China in 2012. Whether it's available for other countries, it's not clear at this time. The efficacy of the vaccine in immunosuppressed transplant patients, it's not clear at this time. This is a case study that I would like to show you. This is an individual, a 62 years old man who presented with complaints of fatigue, diarrhea, RUQ, pain, jaundice, and dark urine. And history indicated that he returned about 3 weeks ago from China. He reported eating street food and sometimes unbottled beverages. So after 3 weeks returning from China, he develops high ALT level, and the routine hepatitis panel shows that there is no hepatitis B and there is no hepatitis A in the patient. However, additional tests that were done for hepatitis E showed that the patient had IgM positive result, which a week later was also positive for IgG, and HEV RNA positive result. When we sequenced the product, we found that the patient was infected with genotype 4, so he imported that from China. He brought it with him. In summary, hepatitis E virus infection can be acquired in developed countries. Infection with genotype 3 is most common, and imported cases can be due to travel or immigration. Infection by hepatitis E virus genotype 1, 4, and possibly 7 might be as a result of immigration. Hepatitis E often becomes chronic in organ transplant recipients, and hepatitis E should be considered in the diagnosis of suspected hepatitis regardless of patient travel history.